So thank you, Giovanni, very much for the introduction and also for the invitation. I'll keep it simple because I think all the backgrounds and the context has been already explained and very thoroughly presented today about the environmental drivers of health, but also as to how some of the solutions could be made. I thought I'd just bring this from I was asked to look at it from a perspective of cardiovascular disease. And as a public health and also an environmental epidemiologist, my usually the focus is from the environmental exposure point of view, and then we assess whether the health effects are observable in the populations. So it was a challenge actually to go back to that clinical understanding and actually seeing it from the other end of the process. So I thought I'd just bring out, we saw a lot of the global burden of disease about air pollution or climate, and Elisa very, very nicely also presented the overall global burden where the air pollution is a top environmental risk. The most recent global burden of cardiovascular disease, which is part of a global burden disease study, highlights that there is, it's about three kind of core risk groups for cardiovascular disease globally. Environmental risks, as you can see, particulate air pollution, so air pollution is at top of that, whether it's outdoor or indoor. Lead is a top priority, so the second or the third highest, past air pollution, and also temperature. So either low or high temperature, which we expect due under climate changes as so the outcomes of the extreme weather events. But also alongside those risks, there are other risks which are metabolic and behavioral risk. And I would like to be cautious is how we think about those, because they are, I'd say, it'll be helpful to think of them as part of this multi-causality for cardiovascular disease. No group of risks will be acting alone when it acts in populations, and also when it acts in a disease upon an individual. But also what is quite important that was highlighted previously as well, that these risks are not equally spread across populations. As we can see, the global burden of cardiovascular disease is much higher in parts of the world than other parts of the world. And these are for multiple reasons, not just due to these attributable groups of risks. So I'll probably just go to a very simple model that I've used in teaching epidemiology, through my lifetime, environmental epidemiology and occupational epidemiology for that matter. And I'd like to talk about the typical disease time course. And I know that all the other presentations were really, wonderful in picture, but I feel like a little bit of actually understanding how we all come from from somewhat two different ends of the typical disease time course. And let's think about cardiovascular disease in this context. So there is, the disease time course starts with some form of exposure, whether it's environmental, behavioral, metabolic, or other. And then we move through the start of the pathological process, which we call induction, in a mechanistic aspect or in biological aspect. And so on, we move towards the latency period where, some damage is already happening in the body, organism, and if exposure is removed, probably is reversible, probably not. And then we move into the preclinical and clinical. So in a normal scenario, we would think from the public health perspective, we sit, or as a public health community, we sit around the A, B, and potentially C. And the medical community is most likely towards the end. So recovery, death from disease, clinical science, and early science actually could potentially be captured, but we're not sure. So it's somewhere in the middle. And I thought I'd just bring those two, the two ends. And the public health, it's as defined by the UK Faculty of Public Health, is a science and art of preventing disease, prolonging life and promoting health through organized efforts of society. And I'd like to go back to that half of sentence later. But it does sit within that area, while the medical profession is a study of practice aiming at preventing diagnosis and treatment of disease, but this in individuals. So I think these are the two key distinctions of those two professions. And the whole my whole kind of context for this presentation is how do we bridge over and how do we are able to transfer that knowledge from one community to the other and actually be able to work together through this training and education process. And a very recent publication, and Giovanni very helpfully presented at the very beginning the exposome concept. And what this publication looks at is the features of exposome associated with cardiovascular health. It's representing all this multifactorial, and we just think that they're not individual factors. They're actually factors that act with each other. So if we start from the risk factors that we saw from the beginning, into look at this concentric web of causation for cardiovascular disease. And therefore, so it is quite key to consider this exposome perspective for cardiovascular health. But moving on into the other aspects, I mean, we heard about air pollution, so we don't just have a multi-causality, we also have unique exposures that cause systemic effects. So the cardiovascular disease is not going to be the only outcome for those exposures, such as air pollution. And as we can see in this illustration by Pope and Dockery, the original publication, is that some exposures will be affecting multiple systems in the human body. And therefore, it's not very easy to capture environmental exposures in the clinical setting. So how do we move forward from that? Who is at risk? And we heard from Paolo talking about the children, to Elisa talking about the mothers and the children mostly vulnerable, and others today, the adult populations, the susceptible populations. So they are. We can think from the clinical perspective, and say looking from the end perspective of the disease progress and time course, is that there are acute effects that are probably most easily captured in a clinical setting, while the cause of that acute effect might not be fully appreciated or understood. There are intermediate effects that are mostly, it could be healthy or susceptible populations, but that is as a result of the damage built up. And therefore, to track what the source of that disease might be a bit more difficult. And the longer term impacts when, we talk about cancers, and they're usually the longer term impacts of environmental exposures are usually through a build up damage on healthy adults, but also the young into adulthood that we heard from in utero to full grown adults. And therefore, so would say that, while in public health and epidemiology, we're able to capture that at the population level, and the doctor's office is much, much harder to be able to understand what the environmental precursors of those diseases or other combined precursors of those diseases would be. And I thought I'd illustrate with a few studies that have taken place. What do we need to know about the environmental precursors? What is some knowledge that would be very useful for the clinicians? It's understanding the sources. We heard about the inequalities, for example, and Giovanni just mentioned the previous professions, and probably now the nurses and the healthcare workers being able to interview and survey as to where do you live, where are you working, or where your parents work, those relevant questions. This one, for example, this study looks at cardiovascular risk and air pollution. And it looks at ischemic heart disease, so one of the cardiovascular outcomes, and mortality for source specific. So, for example, I have biomass burning, which is something that Lisa just talked about, coal, either in an industry or as heating or just part of the living and surrounding of the industrial area. still the same, occupational or residential in proximity. So all of these are, I'd say, a base, I'd say absolutely key and crucial knowledge that could be embedded into the education, just understanding what kind of history do you need to take to determine what the potential environmental precursors could be for the outcome that you see in the office. And I thought another one is because we thought lead is, it's a third, but the second or after air pollution, but the third top risk attributable to that, is attributed to the cardiovascular burden. And lead it can come from multiple sources, but the mechanism of lead to cardiovascular disease is in principle via increased blood pressure. So it increases the blood pressure in healthy adults, or and probably greater effects in the more susceptible on those with or the underlying disease. And what this study found by Federal in environmental research is that the disability adjusted life years, so it's meaning being unwell, increased for the cardiovascular disease. It increased for different types of cardiovascular disease. So if you see the dark, is that there is an attributable amount of disability due to cardiovascular disease, or due to lead exposure, which is directly related potentially to the increase in blood pressure. So those is the basic understanding of those sources of the environmental precursors of disease. But also the other aspect of disease, although this picture is showing the mortality, this is I'd say the learning about air pollution for everyone in the air pollution field, air pollution epidemiology field, is the smog, Greater London smog event in 1952. And what the study showed, so where the red line is where the original study stopped. But the following up was a reassessment by Bale and Davies about 50 years later, to look into what the potential mortality effects were even after the air pollution decreased. And what it showed is that the mortality continued because the damage had already happened. So probably the first susceptible were, which we call, there is a terminology in epidemiology, is harvesting. So most susceptible probably died early on. And while the damage build-up continued from a physiological and mechanistic point of view. And therefore, these longitudinal effects, even the exposures are not there anymore, are absolutely key. I mean, to understand from a clinical perspective. We have examples of mesothelioma, for example, or, that are very, very clear link between the very past exposures long time ago to the outcome a few decades later. So this is, these are just things to build up in understanding from a point of view of a clinical profession. And I thought the climate change and CVD risk, there is, this pathway as to understanding how, the industrial emissions. We heard the wonderful lecture from Andy this morning, as to how climate change could potentially affect directly the cardiovascular sequelae. So it's either through mechanistic pathways such as inflammation or electrolyte balances, and so on, hypercoagulability and thermoregulation. And this leads to cardiovascular mortality. So this is a direct mechanistic impact. However, the WHO, this is the WHO leaflet, that says climate change threatens your health. So it's not just direct heat or cold impacts, or probably, in combination with air pollution. Actually, is where the basic necessities will be disrupted. So we talk about mental health, stress, and all of these could be mechanisms towards cardiovascular health. And I'm just focusing on cardiovascular health as an unnatural focus from a public health perspective, but just to illustrate of all the potential pathways and the way the clinicians could think about this. We've talked with Paolo and Giovanni. We've worked with, on the migrants, actually migrant populations, and the support that they get, or there is, consideration about the food or habitability being disrupted as a result of climate change. So all of those are mechanisms that could affect cardiovascular health through indirect pathways. And I go to this beautiful model by Butler and Harley. This was published in 2010 in the Postgraduate Medical Journal. And I think it's a very useful model to look at the health impacts of ecological and climate change. Then most of the time, we focus on the very primary direct health impacts. And that's what the doctor can see, the heat stroke or potentially a cardiovascular event that they cannot directly relate to what it is, but could think possibly it's a direct impact of those hot or very cold days. But there are others, as we said, climate change effects through secondary pathways, such as biological and ecological impacts, and we talked about malnutrition, or even changes in resource security. And tertiaries through the socioeconomic impacts. And those socioeconomic impacts will, affect through different pathways. And this is just a couple mentioned here, but there are many more that could be affected as a result of such disruptions through ecological and climate change. So just those to be considered in what forms that education and what forms the investigative nature of the profession. And I'd like to go back to that definition of public health, but now we frame it within the environmental public health. And this is defined in the UK, but similar definitions exist elsewhere. So by study in 2006, where environmental public health is a science and art of preventing disease, prolonging life and promoting health, and where environmental hazards are a key factor. So that's the red, is that is through organized efforts of society. And I think that last sentence is absolutely crucial, because this is to solve the ecological and climate crisis and the pressures and the impacts on the population is not a job done alone. And therefore the medical professional and the public health will work, or at least jointly, have a joint mission. And how we achieve that, we can discuss later today. But I would like to also go through this, the Jeffrey Rose's sick individuals versus sick populations. And again, risk. So while the medical profession is towards disease and treatment and prevention of the disease in the individual, the public health looks at the risky populations, because we typically can't identify the individual risk. And therefore, when we talk about the interventions, it's quite important, so that early area of the disease time course, they are mostly most effective. And what this figure shows, if you're familiar with Jeffrey Rose's work, it shows the blood pressure in two different populations. So it's Kenyan nomads and London citizens. So they do have the same kind of spread of the blood pressure distribution across the two populations. However, there is on average higher blood pressure among London civil servants than in Kenyan nomads. And the question is, what creates that shift? Is it lifestyle? There are exogenous factors, because that variability typically is explained by individual variability in the population. That's what the clinician sees. But what the public health sees is exactly that shift, and just how to be informed about that shift, and what can the clinical profession do to reduce and prevent that shift to happen, and therefore move further to the right. Also, just going back to the idea of levels of causation correspond to the organized efforts of society. This is from a publication led by Paolo Lauriola and many colleagues in this room as well, where different types of interventions and different groups of society will be contributing to this intervention. It's only in this context that we can achieve to reduce the population impacts of environmental and climate changes. And I think just linking to the economic argument that we heard from earlier this morning, it seems like I've spoken to all the speakers before I even developed them, because we all overlap in what we want to say. But what this is showing, this is the largest air pollution project in Europe that went on for a few years, some years ago, where it looked at evaluating the effectiveness of implementing interventions and the effectiveness of that in the benefit to the public health. And what this is showing, this is just the monetary value, so I'm not showing here the health benefits of that intervention, but in monetary value, overall, the reduction in SO2 in fuel, and this was the key focus of this evaluation, delivered an average of benefits in a few hundred million euros. So again, speaking the economic language for this context. What I seem to have forgotten to put, I think I didn't give the updated version of this presentation, is that we looked at the intervention, also thinking about the intervention and the medical versus the public health professional. Smoking ban in Ireland took place in 2004, and Ireland, the Republic of Ireland, it was the first country to implement a comprehensive smoking ban. It was implemented under the argument of an occupational safety and preventive measure for protecting the workers in the workplace. But it did deliver quite a comprehensive and first-time global smoke ban. And what we observed in the evaluation of the smoke ban is that the cardiovascular disease had one of the largest benefits, and the stroke, cerebrovascular disease. And not only that, but we observed that the inequalities decreased as a result of those societal interventions. So thinking about the organized efforts of society, it's not just a public health duty, but it's an organized society duty to be able to take those actions. And I'd like to talk about the Titanic effect of socioeconomic inequalities.
Time left.
Yeah, well, this is my last slide, I think, or the last two. And the global inequalities in disease burden and risk factors, they're quite clear, so I don't think we need to focus much more in this one. But going back to this slide, and also to the final slide, I think this is somehow I think it overlaps with what you said, Elisa, in terms of the idea as to how the medical education training for environmental health and environmental climate change can benefit from this knowledge, and how they can put that into practice. And the way we've thought through our work is that not only they need to be clinically aware through education of multi-causality, but they also need to be aware of the community and health and public health principles, and also the knowledge of public health principles in the broad house concept of prevention, but also how this medical practice, professional practice, and not just doctors, as Giovanni mentioned, but also healthcare workers and nurses can implement this. And I thought the investigative skills are absolutely core, and also the advocacy for risk reduction and prevention. So how they are implemented is a question for discussions.
Thank you very much.